That's
you may
nice.
have a better method. But from the posterior view over here on the left of the slide, I see number 5 there, that's the capitate. That's central, that's the capital, that's the largest, and the central, whatever C mnemonic you want to use. So that's the point of orientation for me. And then there's sort of a triumvirate here of major bones. Number 2 is the scaphoid. That's the bone that is adjacent to the radius. It's the one that, as a PA, you should know is most commonly fractured in any type of falling injury, any type of trauma. So the scaphoid is very important, and for that reason, or you should know that it's proximal to the radius. And then number 1 over here, if you take the first 2 letters of ulna and reverse them, you got luna. See what I did there? So it's lunate, lunate, right? And then over here on the lateral side, you've got your thumb side, and you've got, I just call them the trap twins. You've got the trapezium and the trapezoid. The trapezium is thumb, right? And the trapezoid and index, they both have D's in them. High level stuff.
It's terrific.
And then on the other side, I just remember that's the, for example, you're going to learn to palpate your pisiform there. That's the little bone that sticks up right there. That's often damaged in falling injuries too, and compression injuries. It's right beside the hook of the hamate, which contributes to the medial side of the carpal tunnel. And then the last one, the triquetrum, takes us back to the ulnar over here. I just remembered that the triquetrum is the only bone that I can palpate. The finger right there, just medial to that ulnar ligament. And that's how I keep it all straight. But again, all kinds of mnemonics you can use. You have several different illustrations showing the orientation of the bones. You see the pisiform there that's often injured or painful in falling injuries. Scaphoid, as we pointed out, is the most commonly injured or fractured. It's prone, like many of these bones and these complex bones of the foot and the hand and even elsewhere. Oftentimes, when the fracture occurs, there can be attendant avascular necrosis, and that may only crop up later. It may only be evident later, and the symptoms and the issues associated with the loss of blood flow to the bone may only appear later, and that can be problematic for diagnosis. And we've talked about the ligaments and some of the joints already. Again, the metacarpals here are going to be bound by intertendinous ligaments, and you can see that these fibrous digital sheaths of the metacarpophalangeal joints are also somewhat interconnected. The bones out here are the phalanges, and of course these are the phalangeal joints. The singular is phalanx, so this would be the distal phalanx. Each of these bones has a head and a base, as we discussed with respect to the bones of the foot. And then again, don't forget the sequence of enumeration. The thumb is number 1, the pinky is number 5. We also pointed out that there's more motion at the metacarpophalangeal joint, or better range of motion, better movement than is possible in the phalangeal joints. So we also mentioned this earlier. So I think we found at least a couple people that did not have a palmaris longus, but this is the palmaris longus tendon they're coming. And you'll notice that it's exterior to the retinaculum. And it then fans out to form this structure that's analogous to the plantar fascia or the plantar aponeurosis. But this is the palmar aponeurosis. So first thing to keep in mind is that it's continuous with the palmaris tendon. The palmaris tendon is not very strong and really doesn't have much mechanical purchase on this fascial membrane system. There's a slide coming up pointing out that this aponeurosis is protective for the central region of the hand. And actually by that we mean that puncture wounds are less likely, or when they do occur, there's less likely to be propagation of the infection. The hypothenar and thenar regions, although there are small fascial membranes overlying them, are much less protected, and there's much increased risk of infection and injury to those regions. Now, the other thing to keep in mind as you look at the aponeurosis here, we saw a picture of this earlier, that that palmar aponeurosis, here I go with the humerus and the femur again. The palmar aponeurosis will give rise to these circumscribing protective sheaths, the fibrous digital sheaths. And these sort of bind all of the tendons and the ligaments and the bones and the neurovascular structures together externally. So all of this is one big massive structure, but that fibrous digital sheath is the outermost capsule protecting all of the interior mechanics and machinations of the finger. I talked about the thenar and hypothenar regions. Again, the thenar is that little bulbous muscular region adjacent to the thumb. This is the hypothenar region over here. Underlying the palmar aponeurosis is sometimes called the central compartment, relatively protected. And then this region down here where you see the muscles in between the metacarpals, this is the interosseous compartment. And where those interosseous are responsible for the adduction and abduction of the fingers. Don't worry about that. I've deleted that slide about 7 times now, and it keeps coming back. There's something. What's the word I'm looking for? Ghostly about that slide. It just hangs out. So I've already talked about the likelihood of infection. So just be aware that the palmar aponeurosis provides some degree of protection to the central compartment. We're looking here at a condition called Poitrin's contracture. Remember, we used the word contracture in the physiology course to describe the deprivation of ATP to skeletal muscle, and that would cause tetany. So contracture, the most common example of contracture that you will encounter is rigor mortis, but there are other types of preliminary contracture that occur. The term contracture also applies to the restriction of movement that accompanies burns. Here we're talking about a chiefly genetic condition. I don't know that the genetics of this are completely understood. There's probably some type of environmental trigger. But generally, when the individual approaches their late teen or early 20 years, this sort of thing begins to occur. There's sort of a curling in of the fourth and fifth fingers. It's some type of accretionary growth of the binding fascia, and about the only way that it can be corrected is through some type of surgical release. So we're looking at the sort of the very complex mechanical configuration that is necessary to achieve flexion and extension. So once again, just be familiar with a few of these general components. Here's our flexor retinaculum, which serves as the anterior boundary of the carpal tunnel. This is the carpal tunnel down here. You can see the both the profundus and the superficialis tendons running through that carpal tunnel, long median nerve. And then on the other side of that, on the distal side of that, is something called the common flexor sheath. Once again, that acts as sort of a bushing, sort of a lubricating and mechanical bushing to ensure that the tendons are going to the proper location. And you can see the tendons extending out to the fingers from the common flexor sheath. Now, what we're looking distal to that, they removed most of the fibrous sheath. They're showing this blue component as being part of the fibrous sheath. But notice running on the anterior side of the bone, this would be the phalanx here, you have the tendon. The tendon is then going to be surrounded by a synovial sheath there. And then you have that fibrous, that greenish, in this case it's illustrated green, that fibrous sheath that is continuous with the palmar aponeurosis extending into the fingers that's protected. So the tendon is actually running through the middle of all that. You can see that it's vascularized, as is the bone. Yeah.
So does the sheath only connect to the bone area? Does it connect to like the
Well, this common flexor sheath runs under the flexor retinaculum, but this one is not really continuous. It shows some continuity here, but this is really not continuous with these sheaths, which you can see are the little components that extend into the digits. So if that's your question, this sheathing is actually distinct from and separate from the sheathing of the fingers.
Dr. King?
Yes.
So which sheath was cut in the video by the surgeon?
In the palm, oh, you wouldn't see that here.
Oh, it's not
I'm
here?
sorry. Yes, you are right. You're exactly right. It would have been this little bluish capsule in here,
Uh-huh.
not the flexor. Again, the flexor.
Right.
If you were to cut the flexor, there would be you'd have to somehow repair it. I'm not familiar with that thing.
Okay.
I suppose it's possible. So again, we won't watch this thing, but what you're looking at here are these fibrous sheaths or capsules. We saw the tendons earlier, and so the tendons would be running through this thing. But isn't that a remarkable encapsulation? And once again, these are continuous with the palmar aponeurosis. We talked about the intrinsic muscles of the hand. Be sure you're familiar with that, the intended meaning of intrinsic versus extrinsic. These can be classified in a variety of ways. Thenar primarily position the thumb or pollicis. Hypothenar probably preponderantly position the little finger, the digiti minimi. And this is just incredible that there's something ghostly about these slides. I did want you to be familiar with the actions of because I've added this several times too, it just disappears. I need to find out what's happening to my slides. I want you to be familiar with the actions of the interosseous muscle. So you can see their attachment and connection is a little bit complicated. We're looking here in this illustration at the dorsal interosseous and the palmar interosseous over here. So what you'll notice is the dorsal interossea are predominantly responsible for abduction of the fingers. The palmar interosseous muscles are primarily important for adduction. So students sometimes remember PAD, palmar adduction, and DAB, dorsal abduction, DAB, dorsal abduction. And we talked about crazy actions of the lumbricals, right? Both the flexion and extension simultaneously. Looking at the palmar arches here, here's the superficial arch, here's the deep arch. Remember the superficial arch, well actually it's the deep arch, I'm sorry. It's the deep arch that occurs at about the level of the branching of the radial artery. So this would be the contribution of the radial artery to that arch, interconnecting both the ulnar and the radial flows.
Dr. King?
Yeah.
I'm sorry, the dorsal interossi were adduction, ADD, dorsal, and palmar were abduction.
Correct.
Is that correct? Okay, just clarifying.
DAB and PAD.
Oh.
DAB and the way you remember it, if you look at the dorsal, spreading the arrows going this way, dorsal abduction, and then the palmar adduction. So DAB and PAD. There was, and I meant to mention this earlier, there was an easy way to remember the orientation of the anterior compartment muscles here. You don't even need to type onto your fingers to achieve this, but you can see the relative position of the pronator, the flexor carpi, palmaris longus if it's present, and the flexi carpi ulnaris, simply by placing the left hand on the right forearm. You should be able to identify some of these important tendons. Again, the palmaris tendon here. Here's the carpi ulnaris over here. You want to be able to identify the carpi ulnaris because that's going to, as we indicated, that's where your ulnar artery is going to be, and often the pulse is evident there. And then the flexor carpi on the other side, flexor carpi radialis, Extensors, the tendons of the extensor digitorum going to the fingers there. And we've already talked about the components of the anatomical snuff box. So that's pretty much all the surface anatomy you should be familiar with. Don't know if you'll have any patients with polydactyly. This is a genetic condition. What's wrong with this picture?
That's awesome. Must be hard to buy gloves.
This one has even more.
Oh, crap. He's an awesome piano player. He can play so many notes at the same time. Spider.
Uh,
We're missing anybody? This keeps falling off. Really annoying.
Okay, so let's move on to a discussion of the thorax. By the thorax, hopefully we're going to find more overlap now between the two portions now that we've dispensed with the
Thorax,
discussion of the limbs. We're going to be talking about, of course, the physiology, the cardiovascular system, and the pulmonary system. So hopefully there will be to some degree of overlap between the two, although I will say that what I will sometimes need to do, especially in these short summer courses, is move a component of one that is normally taught in one course into the other just for the exigencies of time. But in any case, the thoracic compartment really consists of three subcompartments. There are two pulmonary or pleural compartments, and you could use either term, the lateral pulmonary or pleural compartments. And then between those two is the compartment called the mediastinum. And that's where the heart, pericardium, the great vessels, the thymus, esophagus, trachea, and so on would be located.
Oh,
The
2 days ago.
thoracic wall will receive some of our attention to the extent that thoracic wall includes a number of critical bony and cartilaginous structures, as well as the intercostal muscles, the intercostal arteries and veins. There will also be intercostal nerves in this region, all extending through the thoracic wall. Remember, one of your primary objectives, especially as we get into a discussion of the thorax and the abdomen, is being able to name all of the tissues, all of the structures that must be traversed in any type of surgical procedure, or must be, or would be traversed by a puncture wound. So what we're looking at here is from the Visible Human Project. This is the female visible human. This is the woman whose husband donated her body to science, and she had a number of odd anatomical qualities that were noted that had not previously been really studied. But one of the things you'll notice, she was a fairly large woman, and you can see the rather substantial size of what's called the camper fascia, or the subcutaneous fat that's present in the thoracic wall. But for the most part, when we talk about the thoracic wall, we're going to be talking about these musculoskeletal structures that provide the bony cage or rib cage, protective rib cage. So you can also see that the diaphragm. The diaphragm is the inferior margin of the thoracic cavity. Of course, it has a highly irregular shape. So let's talk a little bit about the skeleton that frames the thoracic cavity. We'll notice, first of all, that there are 12 ribs that make up the rib cage, 12 ribs on either side. The ribs extend posteriorly from their attachments with the transverse processes of the vertebra. And some of these, certainly the first 7, will attach directly to the sternum or the breastbone up here. Now, when I say the ribs attach, notice that's not quite true, because the anterior component of each of these ribs is actually cartilage. This is the bony compartment that you see here. This purple is actually cartilage. So the anterior component, the anterior section there, is actually cartilaginous. We differentiate the true and the false ribs. The true ribs connect directly to the breastbone or sternum. Ribs 8 through 12 connect either indirectly, you can sort of see them lining up here, or the last 2 ribs, the 11th and 12th ribs, do not connect to the anterior cage at all. Those are called the floating ribs. Posteriorly, you can see the costal connections of the vertebrae with the ribs. You'll also note the considerable downward slant, posterior-anterior tilt of the ribs, so that most friend sections of the ribs that you see in the anatomical literature are actually taken obliquely. So the true ribs, the false ribs, and the floating ribs, this is a bit of an anatomical scholasticism. Whether you wish to include the floating ribs as part of the false ribs, that's fine with me, but just be aware that by floating rib, we mean that there is no direct anterior attachment of the rib to the sternum. The rib, you can see, attaches at its head posteriorly to the vertebra. There are usually 2 points of attachment. There's the attachment with the vertebral body, and then the attachment at the costal facet with the transverse process. The head attaches to the vertebral body. It's the tubercle that attaches to the transverse process. Between the head and the tubercle is the neck. You'll see, and this is not consistently named, but you'll see there's a little inferior tuberosity where the rib begins to curve significantly. That's usually called the angle, although in some of the, especially the medical literature that you see online and that your patients will be reading, this region is called the angle. So I'm not sure what to tell you, but the proper anatomical description is here. In any case, the rib, most of the typical ribs, the ribs, say 3 through 9 or so, have a very, very sharp curvature, and this is where they're most prone to fracture, most prone to mechanical breakage. Additionally, on the underside of each rib, starting at about where the curvature tends to reflect back, you'll notice there is a groove that's called the costal groove. And we're going to find that the intercostal artery, nerve, and vein run along that, at least at that point, run along that costal groove. So I'm not too fond of this notion of atypical ribs. But we're looking at the set of the first pair of ribs here, ribs 1. These are usually called atypical because they're so short and stout. As a PA, if there's an injury or damage, if there's breakage of the first rib, that generally means that there's extensive damage somewhere else. It would take a significant trauma to break the first rib. But you'll note that it attaches to the sternum and the cervical vertebra. Some individuals will have what are called supernumerary ribs. By supernumerary, we simply mean, like we saw with polydactyly, a number in excess of the normal number of structures. In fact, you'll have patients that occasionally have both supernumerary cervical ribs and lumbar ribs. Lumbar ribs are less common, but they can be confusing. Now, we're going to talk later about a condition called the thoracic outlet syndrome, in which various brachial and thoracic structures can get caught up in the complex musculature and bony projections in the cervical region. Naturally, supernumerary cervical ribs would contribute to that problem. You would have more bones getting in the way of the brachial plexus, for example, and perhaps the associated blood vessels. The costal cartilages we've already talked about. The space between the ribs or the anterior costal cartilages is called the intercostal space. More specifically, that anterior space between the costal cartilages is called the intercostal space, and it's named for the rib above it. So each space is named for the rib that is immediately superior. And we're going to see later that is a critical space because as we pointed out, the intercostal artery, vein, and nerve are all running in that space, along with associated structures we call collateral vessels. So here we can see another illustration. This is in the AP revealed in the anterior costal component. The costal component, this is all cartilaginous. And as we age, this tends to ossify, as does the xiphoid process of the sternum, making it more brittle, sometimes increasing the force needed for normal respiration, but also increasing the likelihood of fracture, damage, mechanical damage to this region, especially in falling type injuries. I have three grim cases over here. If you look at the animations, the little videos here, this is something called flailed chest. Now, as we will learn in the physiology, the ability to breathe properly depends upon the mechanical integrity of the rib cage. That rib cage is going to be moving up and down. It's going to be changing its conformation, and that is entirely responsible for our ability to move air into and out of the thoracic cavity, into and out of the lungs. If for any reason the rib cage is compromised, there are multiple fractures in the ribs, sometimes there will be a detachment of the internal wall of the thorax from the ribs, and you get dramatically impaired ability to breathe on the part of the patient. So in flailed chest, the main problem, aside from the pain and mechanical issues that have to be addressed, you have to find some way to repair those ribs. It is very likely that the patient's going to have to be on some type of assisted respiration, some type of ventilator. Sometimes you can see at the top there, can you see what probably caused that injury? Yeah, probably run over. And that would be a classic cause of flailed chest. But it requires immediate attention to restore respiratory function. So we're looking at the breastbone here. Again, the sternum. The sternum has three parts. The uppermost part is the manubrium. You can see there are several little notches we'll talk about in association with the manubrium. The central portion is called the body, and then this distal portion, which may or may not be present in various shapes and configurations, is called the xiphoid process. Or as I saw the other day on the internet, the typhoid process. We can also see in the illustration here the diaphragm. So notice the diaphragm arches way up into the rib cage, and the diaphragm, as we've indicated previously, is formally separating the abdominal cavity from the thoracic cavity. So don't assume that what's called the costal margin here, this is called the costal margin, is the lower limit of the thoracic cavity. In fact, the abdominal cavity extends superiorly into the rib cage. So I mentioned several notches with which you should be familiar. You can see in the manubrium here, there's a superior jugular notch. You will often use that anatomically as a reference point to get your bearings. Then there is the notch immediately lateral to that to accommodate the clavicle. So the clavicle attaches to the manubrium. And then immediately lateral to that, or below that, is the notch to accommodate the first rib. Another important landmark, you can use this to count the ribs and to locate some other structures as well. For example, the trachea separates into two primary bronchi at about this level. It's the sternal angle of Lewis. So where that manubrium meets the body there's a little convexity. And as I say, that convexity is about the level of the second rib. You're going to learn to locate it there. But it again, serves some other important, serves as another way to locate interior anatomical features as well. And then the body is then also going to have little notches there, little depressions to accommodate the costal components of the anterior ribs. These are the costal notches. And then inferiorly, the body will give rise or give way to the xiphoid process. Their highly variable shape tends to change shape as we age. In some individuals, the xiphoid is pointing out. In some individuals, it's depressed. In some individuals, you can open hands with it, as you can see here. Again, sternal angle of Lewis at about T3, T4. That'll crop up again and again. And as we mentioned it, along with the costal components, tends to ossify as we age, generally calcified by the time we reach mid-age. Now, there are a number of procedures that require access to the chest, and of course, this rib cage presents a problem. Where how are you going to, if the heart requires a bypass or corrective or valvuloplasty or some other procedure, how are you going to access it? There are all kinds of procedures now that are minimally invasive, endoscopic, do not require the extensive sort of surgery we see on the left. But I think this type of access is anatomically useful. This is called a sternotomy, and involves simply cleaving the sternum using retractors to separate it. And then, of course, upon doing so, you have immediate access to the pericardium and the heart. And there are a number of reasons this would be preferable to actually cutting through ribs. And you can see even over on the other illustration here, they're cutting between the ribs and the endoscopic procedure or the laparoscopic procedure. So let's look at a brief surgical procedure, a brief sternotomy here. Full median sternotomy. 75-year-old ascending aortic enlargement. So here we go. By the way, there are a number of spelling errors down there, but let's not worry about that. So we were spared the music that usually erupts at about this time when a scalpel is exposed. Notice how careful he is, getting down to the subcutaneous fat. Very important to cauterize as you go. So the instrument he's using is both cutting and cauterizing. And there are various ways that can be done, but that's the most common way with the skin. See, there's a typhoid appendage. What should that say? Yeah, xiphoid. I knew I'd seen that somewhere. Could be a typhoid appendage in there somewhere, and you have to be careful. So he's very careful. Oops, with the bleeding there. I'm just going to try to speed that up just a little bit. He's making sure he's addressing all the potential bleeding. He's palpating that sternal notch. Make sure the location is where it should be. And then you bring out the remnants. There's an electric saw. You see how very precise the movements of his hand are. So now you want to make sure you limit the bleeding once again. Various ways to do that. All kinds of powders, osmotic powders that can be thrown in there. Hemostat type powders that reduce the bleeding. In this case, he's using bone wax.
Show the retractors. That's crazy when he moves them.
By the way, you can see what they've done at this point. Let's watch them insert the. There we go, the retractors.
Yeah. That's crazy.
So what are we looking at there?
Pericardium.
Yeah, the thymic remnants that here we go. That's surprising in a 75-year-old individual. Usually that's pretty much gone by that age. But and we'll look at this later, he's accessing the pericardium at this point. Notice it says large venous vessels are usually clipped rather than cauterized. Why would that be? Why would you tie those off rather than to attempt to cauterize them? Well, in some cases, yeah, this is permanent. It wouldn't be practical in many cases to restore the vascular. These are veins. In some cases, oftentimes if they're larger, cauterization won't work anyway. It just creates a mess. It's kind of like if you've ever tried to melt plastic. So the ligature seems to work a lot better. So now we're down. It's going to be soon accessing the pericardium. I wanted you to see the heart down there as he cuts through. Also, did you see the very large aorta? There we go. Now we can see it. The heart. Yes, and you can see components of the fatty tissue that's encapsulated. But what I wanted you to see also, remember, what was the diagnosis of this patient? Yeah, so if he doesn't show, I want to go back and show you that. You may have seen that earlier. It's quite something. But in any case, that's the beating heart. Yeah, that would be the pericardial fat. Yeah, there we go. Get that aorta. Oh, see, this is the aorta here. Whoops, that wasn't very helpful. See, all of that
Huge.
is aorta. It's almost the size of the heart.
Yeah.
And in the physiology, we'll talk about a little bit why that might occur. All right, so in any case, that's a sternotomy. Yeah, I would think this is exploratory. We know he knew that probably from the imaging that the patient's aorta was massively large. I think he's looking for irregularities that might not show up on the imaging in the other vessels as well. I've said several times that I would encourage you to sit down and get the netters. You have all those netters illustrations online with your HPD library subscription. And compare those to some of these visible human projects. This is the male here, you can tell by the very large pectoralis muscles and so on. But here was the sternotomy. So we went through the camper fossa, superficial fossa that cut through the sternum. And so as you look at, you can see there's a little, what's called the sternopericardial ligament here, for example. That may be attachment, highly variable from individual to individual. And then you see some of the pericardial fat that he was cutting through too. Again, you have to be very careful because that is a very vulnerable region. So pectoralis major out here, you can see the lungs over there, you can see the heart, the vertebra, spinal cord here, vertebra. What is that? Yeah, good, the esophagus there. The aorta there. But what that thing on the other side would be.
Vena cava.
Huh? No, the vena cava would be massive. Any type of, not at this level. This is kind of hard to see. This is sort of superior. Probably the azygos. As we'll talk about that later. Probably large azygos vein running posterior. And so these Netter's images, I'm not going to ask. I'm not going to give you a transsectional test and ask you to identify the small structures. But these are very useful in trying to work through those. All right, so let's come back to this slide. I'm going to look at this one first. So superiorly, we have something called the thoracic inlet. And the thoracic inlet is framed, as you can see there, by the spinal column, the first rib, and the sternum. And then inferiorly, you have the thoracic outlet. And the thoracic outlet is just the inferior margin of the costal margin and the spinal column and so on. Sort of indicated by the purple lines there. Thoracic inlet superior, and the thoracic outlet inferiorly. And of course, and we'll talk more about the thoracic outlet later. Thoracic, the dotted or the dashed line you see there is more or less the margin, the superior margin or excursion of the diaphragm. And these would be more or less the attachments, not quite from the diaphragm, more or less corresponding to the attachments of the diaphragm. All right. The confusion that inevitably arises is that the anatomists and the clinicians do not agree on the meaning of the thoracic inlet. So be aware that anatomically, this is the thoracic inlet. You, as a PA, will have to deal with something called thoracic outlet syndrome. Thoracic outlet syndrome, and what you need to appreciate is the anatomical inlet is the clinical outlet. All right? So when we talk about thoracic outlet syndrome, we're talking about an impingement, compression of structures in this region up here. You can see how that might happen here between the clavicle and the first rib. This would be pretty dramatic. It's costoclavicular syndrome, but it's a type of thoracic outlet syndrome. I've known several students over the years that have this, and as they turn their head, there would be an associated distension of cervicocephalic blood vessels and so on. And sometimes they have pain, sometimes. In fact, especially in patients that have had clavicle breakage, a quick or sharp turn of the head can cause a sudden, very intense pain because of the consequences of the breakage and the callus that forms. But there are a number of ways this can occur. We won't, again, this is not a pathophysiology course, but what I do want you to notice is here, this would be the normal anatomy. We can see the brachial plexus passing between the middle and anterior scalene muscles, the entire plexus, components of the plexus along with the subclavian artery. But what's happened up there at the top? Some of them have decided to take another path. And when that happens, depending upon how it happens, that can present problems. You can get compression again with contraction of the scalenes causing any number of issues. The most common sites of compression are there at the scalenes. That would be the first. The second would be between the first rib and the clavicle. And the third, which is fairly uncommon, is in the region of the pectoralis, the proximal attachment of the pectoralis muscle, depending upon the particular anatomy of the patient. But in any case, all of these would be examples of thoracic outlet, bearing in mind this inevitable terminological confusion. Yeah.
Do they sometimes remove ribs for this to fix this?
Remove ribs.
I mean, I've seen that. There's a girl who had, where I work, who had this, and she had like the first two ribs.
The first two ribs removed for thoracic outlet syndrome. That's remarkable because there would be a lot of problems, so for example, my first question would be, how did that affect her breathing, especially on both sides? See, all of you seem normal, right? But I've heard the future stuff. And then there are a number of muscle attachments to those structures. I'd have to see. Did you actually go there? Did you actually look in there? I'd have to. I've heard of the first rib being that there are all ways that a portion of the bone can be abraded and so on. I've never heard of two ribs being removed. I'll check into that. Interesting. And you're sure that you didn't have some other issue? She didn't have thoracic outlet. Because I've done several students that had severe manifestations. I mean, they didn't resort to that. Another problem that can occur that you should be familiar with, and we'll finish with this, is if you look at the AP revealed cadaver here, you'll see these two yellow nerves here. These are the phrenic nerves, and you know the phrenic nerves innervate the diaphragm. They innervate some other structures too. They, for example, they innervate the pericardium. They also innervate the diaphragm. And I think you can imagine what might happen. There might be unilateral loss. There might be a loss of innervation to one side of the diaphragm, either for neurological reasons or some other mechanical reason. And when that happens, what we're going to find in the physiology is that when the diaphragm contracts, it flattens, paradoxically, it flattens. And that spreads the bottom of the rib cage and does some other things as well. But if one side is able to contract and the other side is not, right? As one side contracts, the air is going to be pushed down on the other side. And so as one side is going up, the other side is even going farther down if it can't contract. And thus you get something like what you see in the top right there. You get significant impairment of breathing or respiration on one side. There are all sorts of ways this can be addressed. Sometimes they can use one nerve to innervate both sides. There's some other things that I've seen done as well. But generally what you get with loss of phrenic function on one side is hemiparalysis of the diaphragm. Excuse me. All right, we'll stop there and we'll pick up what tomorrow is physiology.